Welcome everyone to our AIHI webinar series from the Australian Institute of Health Innovation at Macquarie University. My name is Chrissy Clay and I'm the coordinator of these webinars. We've got a lot of people still joining us today, which is fantastic. So we've just got a brief chat at the start before we start our presentation, which is on the topic, can we have a better healthcare system to 2030? Our presenter is Professor Jeffrey Braithwaite and our host is Professor Yvonne Zurynski. So firstly, I would like to acknowledge the traditional custodians on the land on which we are meeting today at Macquarie University, that is the Wallumattagal people of the Darug Nation, and pay our respects to elders past, present and emerging. We would also like to pay our respects to the land on which you are all joining us today and welcome any Aboriginal or Torres Strait Islander people in the audience. If you have any questions during our presentation, please put them in the Q&A and we will get to as many of those as we can at the end. I'd now like to hand over to Professor Yvonne Zurynski, who is a Professor of Health System Sustainability at the Institute here and at Macquarie University. Thank you, Yvonne.
Thank you so much, Chrissy, and welcome everyone to this Australian Institute of Health Innovation webinar. Where we're exploring the question, can we have a better healthcare system by 2030? So I'm Yvonne Zurynski, I'm Professor of Health System Sustainability at the AIHI, and my job today is to tell you a little bit about the Institute and to introduce Jeffrey, of course, and to moderate the discussion at the end. So as Chrissy said, it would be really great if everyone would use the Q&A function, please, to post your questions. And don't wait until the end, as you may forget your questions. So just post them into the Q&A as you think of them. So a little bit about the AIHI. Our goal is to co-create high-impact health services and systems research that drives positive change in policy, practice and behaviour for the benefit of all. We are comprised of 4 core centres. And you'll see that slide in one moment. There we go. The core centres are the Centre for Healthcare Resilience and Implementation Science, led by Professor Braithwaite, Centre for Health Systems and Safety Research, led by Professor Westbrook, Centre for Health Informatics, led by Professor Kayera, and the Macquarie University Centre for the Health Economy, led by Henry Cutler. We also have a number of NHMRC-funded centres, so the Partnership Centre for Health System Sustainability, the NHMRC Centre for Research Excellence in Implementation Science in Oncology, and Centre for Research Excellence in Digital Health. So we are a fairly large institute, and really our goal is to generate evidence to improve healthcare. And we can summarise the huge amount of work that we do, and it's very varied work, but we can summarise it into, 6 different areas. So we want to understand the relationship between system complexity and system performance. We do evaluate the impact of interventions in health workplace and social outcomes, understanding behaviour as a basis for practice improvement, using artificial intelligence as a technique to support evidence-based decision-making, designing models of care and ways of working which provide improved safety and quality, and applying an economic lens to evaluations and policy development. We hold approximately $50 million worth of research funding that we manage at the Institute, but we are also involved in many collaborative grants with another 80 million or so, where we are involved in different projects managed by our collaborating institutions. There are about 129 different projects happening at the one time, and we publish about 300 peer-reviewed papers each year. If we go to the next slide, you'll see that we have a very good looking and very smiley workforce, and we need a large group of dedicated people to do all of this work, and here they are smiling to you. So my next great pleasure is to actually introduce Professor Jeffrey Braithwaite, who is the founding director of the Australian Institute of Health Innovation. He is also director of the Centre for Healthcare Resilience and Implementation Science and Professor of Health Systems Research at Macquarie University and president of the International Society for Quality in Healthcare. So as you can see, he is a very busy man. He leads health services and systems research, has an international reputation for his work investigating and contributing to systems improvement. He has particular expertise in the culture and structure of acute settings, leadership, management and change in health sector organisations, quality and safety in healthcare accreditation and surveying processes in the international context, and the restructuring of health services. Professor Braithwaite has presented on health systems improvement to the World Health Organization, Harvard Medical School, the OECD, the International Society for Quality in Healthcare, the UN and the European Union. So there is no one better to speak about improving the health system to 2030 than Professor Jeffrey Braithwaite. Over to you, Jeffrey.
Thank you, Yvonne. That was a very fine introduction. I hope I can do justice to all the things, all those nice accolades. And thank you, Chrissy, for coordinating all of our webinars and all the work you do in outreaching our work to people across the world. So the title of this evocative talk, we hope evocative, is Can We Have a Better Healthcare System by 2030? And of course, the back canvas to that is that we have huge headwinds and very challenging times for health systems in Australia and across the world. So let me take you on a journey. I've presented aspects of this talk to many international conferences recently, as Yvonne indicated. But I'm trying to now think through how do we apply this to Australian healthcare? We don't just have one health system, we have multiple health systems and multiple layers in a very complex health system in Australia. So how do we apply some of the Institute's knowledge, ideas, theories, frameworks to try and produce better healthcare by 2030? That's the task. Please come with me on this journey. So it's good to start with what's the problem. Now you will have your own views, those of you who are policymakers or clinicians or fellow researchers or patients groups or leaders and managers, all of the stakeholders in healthcare, you will have your own vantage point and your own understanding of the challenges of healthcare. Let me walk through the challenges from a research perspective, and I'm sure it will gel with your particular take on the headwinds, the challenges that we're facing. So it takes on average 17 years for only about 14% of new discoveries to enter practice. There's 36 million papers in PubMed, so there's a huge store of information on which we can draw, but there's a slow burn in terms of getting all of those papers, studies, ideas into clinical practice on the front lines of care. And around 60% of care is in line with evidence or consensus-based guidelines. That differs by setting and it differs by condition. About a third of care is waste of some kind. That could be overtreatment or undertreatment or test results that never get seen. They get done but not seen, or bureaucratic layers that make it difficult to deliver care efficiently. There's lots of ways that we can describe healthcare as wasting resources or not fully deploying them for the benefit of high-value care to patients. And about 10% of patients are harmed when receiving care. Most of that is not so consequential. It might be an error or an adverse event, but it doesn't actually result in big harm to the patient. But there's still a proportion of preventable harm that is significant, that's delivered by health systems. So those numbers are, in essence, the nature of the problem that we in the Institute are working on, and I'm certainly working on those. So let's think further when we get to the end of this talk about those three essential numbers, 60, 30, 10. Many health systems have many, many indicators of their performance, some hundreds of indicators. But if we were to beat those three numbers, get higher quality care, improve the 60, reduce the waste, improve the 30, and reduce the harm, improve the 10, we'd have a better health system. Now, it doesn't mean when we say 60, 30, 10, that 60 plus 30 plus 10 is the 100% of care, because these are Venn diagrams and they're overlapping. So you can have high quality care, but it's waste because the care is delivered of high quality, but it was over treatment or under treatment, or we delivered unused test results at the end of the patient's stay. No one read them. So you can have guideline-based but low-value care. You can also have waste and harm, wasteful, harmful care. That's the overlap of care that shouldn't have been delivered. It was ineffective, or it was excessive bureaucratic layers to it, but you also harm the patient. And you can have harmful quality care. You can deliver high-quality care, but you can have an error during the care process. So this Venn diagram, in a snapshot, explains much of what we're working on in the Institute to try and improve those numbers. So that's the problem, my take on the problem. You'll have your take. What do we think about in terms of the solutions? Well, there's lots of solutions that people have suggested are the way to improve healthcare. And so one is the knowledge pipeline. This is a common kind of picture. You can go to Google Images and find lots of these. You start with more research and you develop that research, conduct trials, do health technology assessment, do some health services research, the sort of thing we do at the Institute amongst those 129 studies that we've got going on. Do some knowledge management to try and get care and evidence into practice, care improved, evidence into practice, and then improve the delivery system. The problem with the pipeline model is it's very linear and it's really an idealization. Otherwise, you wouldn't have those numbers of taking 17 years for only 14% of evidence to get into clinical practice. There's lots of barriers in the pipeline and fractures in the pipeline. And so we end up with system failure, the system not being as evidence-based as we would want it to be. The other reason why it's hard to beat these numbers is it's a complex system. Now, I don't need to tell anybody who works in the health system that healthcare is a complex system. But we've done a lot of work on this to understand the nature of healthcare and the fact that it's not linear, but it's highly complex. In the jargon, it's a complex adaptive system. So let's have a look at that. So the pipeline suggests that solutions are linear. If I do X, I will get Y. If I issue more evidence-based policy, it will be taken up on the front lines. If I do another study, and it's an RCT, a randomized trial with a control group, then this will apply to a population of patients. But the healthcare system is complex, incredibly complex, and such linear solutions don't bear as much fruit as we would like. Now, complex systems are everywhere, and many people in other disciplines outside of healthcare are working on complex systems. So your extended family is a complex system, a complex adaptive system. It is changing across time. Your computer system that you're tuning into and video streaming on this webinar is connected to lots of other devices, printers, other internet-enabled devices, and so that's a complex system. The parliament and the political process is a complex system. People say the human brain has more connections at the synapses than there are atoms in the universe, and it is the most complex system in the universe. I just want to say some systems look complex and they're not necessarily complex, but some people believe that all systems where we involve people and groups of people are complex systems. So a question is, if I'm putting a claim to you that resonates, and the claim is linear solutions won't get you very far, or they'll only get you so far. And the idea that if you do X, you'll get Y doesn't really hold in a system like healthcare. Then we need to think through, how does care actually work in practice? How does this complexity manifest? So we've done a number of studies on this. We've encapsulated quite a lot of them in this white paper that's available on a download that we published a couple of years ago, and it's available on our website. Lots of people have downloaded this, and it's become quite influential, where I led a team looking at, if healthcare is complex in the way I'm just about to describe, then what do you do to try and improve it, navigating all of this complexity? So what are the properties of complexity? I'm now, in a couple of slides, going to summarize what's in a 100-page white paper that you can download and read at your leisure. So it has these properties. These are the properties of a complex system like a health system. It has lots of agents that are interacting, are relatively self-organized. Clinicians on the front line, groups of people doing stuff in healthcare are relatively self-organized once they get going. They're collective. It's about a collaborative. They're clustered in networks. There's lots of rules applying to how behavior occurs. There's a property of complexity called emergence, which is a technical term which really means things happen that are unexpected. Things emerge. And one level up in a complex system are things that you didn't really necessarily anticipate. There's a lot of uncertainty. You don't get, this is not just like playing chess where there's an optimal chess game. That's complicated, but it's not complex. Or firing a rocket ship to the moon is not uncertain, even though there's lots of moving parts. It's not complex. It's a complicated problem. There's lots of uncertainty. There's lots of adaptation. Complex systems adapt across time. They're dynamic. Lots of stuff happens bottom up, not just top down. In a complex system, you're not waiting all the time for some instruction or a guideline or a new policy or a new study. You're getting on with the job. So a lot of behaviors are bottom up. Health systems and complex systems are always transitional. They're always going from one state to another. And they're governed by feedback. Systems crave enough information to make the next decision. Clinicians on the front lines in teams, policymakers. And there's a property of complexity called path dependence. And what that means is where you came from matters. Where you started in your history, way back in the origins of your system or your hospital or your general practice or your community setting, matters. It shapes what happens later. We call that culture. The culture is resonant with what happens in the past. So that's a quick snapshot in a slide of what we're talking about when we're talking about a complex adaptive system and the characteristics of complex systems. So key features in a snapshot again. Think about 4. There's populations of agents, people interacting. They're artifacts, they're stethoscopes, computers, MRI scanners, tests. They're interacting dynamically. Things resonate over time. And there's lots of emergent rules and governance mechanisms, top-down and bottom-up networks. So that's the key features of complexity. I've just summarized in 2 slides an entire 100-page downloadable white paper. But of course, we recommend you download it and read it at your leisure. But we do research in this area. We try and unbundle and understand the complexity of the system. So one tool that we use, one research method is social network analysis. So about 12 years ago, we joined a collaborative translational cancer research network in Eastern Sydney with our colleagues at UNSW, Prince of Wales Hospital, St Vincent's on the eastern seaboard, those health systems to the east of Sydney. And when we started, and Janet Long and I and a number of other people did this work, and Janet did a lot of this analysis for us, and really became a world expert in this kind of research. When we started, the lots of people in the network trying to get better cancer care to the populations of patients in Eastern Sydney. The dots are people and the lines are connections between them. And if there's no line between them, they're not that connected. And so that's the network in 2012. This is the network in 2013. The network in 2015. The network in 2017. And this is our network in 2021. So what you can see is, as we did work in this area, longitudinal work, and mapped who was collaborating with who in the complex system, who was connected to who was talking to who was writing a paper together, delivering care in a multidisciplinary team, collaboratively, we were creating an enterprise of people who were striving to get better evidence-based care for cancer patients in Eastern Sydney. We're also the implementation science group, Janet Long, myself, Steph Best, Natalie Taylor, a whole bunch of people. We're the implementation science group for Australian genomics, trying to take genomics out of a research project into clinical practice. And so before 2016, this was the network of specialists, geneticists, researchers, all sorts of people involved in trying to create a learning community in Australian genomics. And this is what it looked like by 2018. So we created a collaboration. And what you can do with diagrams like this, which depict the complex system that we're trying to act on, that we're trying to leverage to improve, you can see we have many more opportunities for collaboration and better care, and a better group of people, a larger group of people, to solve problems along the way. We think this sort of research is really cool, and it helps us uncover the non-linearity of the health system. It's in all its complex majesty. So, in summary, the key lessons: healthcare is complex. It's a complex adaptive system. It adapts over time. It doesn't necessarily wait for the next study, the next policy, next guideline. It's delivering care constantly. Behaviors are emergent. Things happen across time. Bottom-up behaviors produce localized rules which govern how clinical teams operate as much as the policy document. Linear models in a system this complex, if I do X, I will get Y, only take you so far. And we have to factor all this in if we're going to improve healthcare. So let me drill in. Now that I've established, I hope, a platform of understanding about what we're trying to do when we apply complexity to our health system problems and the kinds of studies we do. And I'm only drawing on a couple of studies in the Institute. It's almost a treasure trove of studies, as Yvonne pointed out, with the work that we do. There's 300 of us or so associated with the Institute or working directly in it, who are all collaborating over all those projects and all those studies. So let's drill down and let me give you an example in practice that we're working on right now. And the example is climate change. So you know the problem if you work in healthcare. Climate for healthcare is a bidirectional problem. On the one hand, healthcare is a major emitter. Between 4 and 8.5% of all emissions come from healthcare across all industries. On the other hand, healthcare is on the front lines, especially emergency departments or primary care settings, because as we get heat spikes or droughts or floods or other problems that are exacerbated by or directly caused by climate change, bushfires, for example, or more likely because of climate change, then healthcare is on the front lines having to deal with all those patients. If you think about COVID-19 as a specific problem that was short and sharp, it's only going to last 3, 4, 5 years. Climate change is as challenging for healthcare, but it's a much slower burn, and it's going to unfold over decades rather than 3, 4, 5, 6 years, however long the pandemic lasts. So we've done a lot of work. We're just about to publish a paper to frame a series in the British Medical Journal on climate change and what clinicians can do to help. We've also got a new book coming out in the last quarter of this year, edited by Yvonne Zurynski, myself, and Dr. Kayleen Smith. And we've got several systematic reviews under review right at the moment, which will be published, we hope, towards the end of this year in big journals. So we're trying to say, what's the place of healthcare in climate change? And I'm going to draw on some of these studies that we're doing right now. These are fresh, right off the study, fresh to our work. Here's an example. We're looking at internationally which health systems produce most carbon dioxide equivalent emissions. Healthcare has a big footprint, as I said. So low and middle income settings produce less carbon dioxide emissions or carbon dioxide equivalents, and leading through all the way to the US, which is the world champion and is the most largest footprint and produces the most emissions per person. Australia produces quite a lot of per capita emissions compared to other countries. And what we've been working with is there are three scopes to healthcare's contribution to climate change. Scope one is direct emissions. Healthcare facilities produce emissions. Scope two is the direct purchases of energy and use of energy which healthcare uses. And scope three, healthcare sits in a supply chain. It requires water, drugs, food, consumables, disposables, all the things you see on the list there. And by far the largest footprint on climate change that healthcare can influence is scope three, because it's in a chain, in a network, which is another reason why we do that network type analysis, to understand the whole network, not just individual components. We've done two systematic reviews. One is a comprehensive search on the effects of climate change on health systems. How is healthcare need to be more resilient and strengthened in the face of more patients coming our way, increasingly because of healthcare, because of climate change? The patients arriving with new conditions or more conditions because exacerbated by climate. The second thing is how health systems can contribute to climate change and climate reduction by reducing its own carbon footprint. The first systematic review, this is the model that we created out of this. It's going to be published in due course. It's under review. And we've created a model. We really like depictions, not just words in studies, not just papers in journals, but we really like models that help us understand this. I won't lecture on this too much. It's going to be available in a very big journal, we hope, very soon. But it shows you how we're trying to understand all the internal and external to the health system manifestations of what healthcare has to do to cope with climate change. The second one is ways to reduce healthcare's impact on climate change, on the climate, to reduce its own greenhouse gas emissions. And you can see this is another complex problem. If you're a hospital or a general practice or an aged care facility, you need to take action to become greener, to reduce throwaway stuff, to work on your anesthetic gases that create a lot of contribution to greenhouse gases, and so on and so forth, to decarbonize the supply chain and influence your suppliers. What are the remedies? If we think through what I said about complexity and what I said about climate change as our example of a complex problem that we're working on to try and improve healthcare now and across to 2023 to 2030, what are the kind of remedies for our linear thinking? Look for interconnections in the system, not just a specific problem. Consider that you actually can't see very far ahead. Healthcare is uncertain. There's lots of moving parts. You can't necessarily predict what's going to happen. Look for patterns in the system instead. Be careful in attributing cause and effect. We kind of tend to think, if I do X, Y will occur. We think in a linear way, but that's rarely the case in healthcare. Generate new ideas beyond your own resources when tackling problems. You often, if you're sitting in the health system trying to improve things, aren't the sole arbiter of the solution. In a system this complex, you need help. Keep in mind that systems never change in a one-to-one relationship between what you want for them and what you get, what actually happens. Doesn't mean your work is futile in trying to improve healthcare, but what it means is you rarely get what you actually intend. There's lots of unforeseen consequences in a complex system. We think it's really useful to model the system, and that's why we do social network analysis and other modeling. Just like climate scientists are modeling the climate and the weather to try and understand the effects of climate on our long-term weather systems and climate patterns. We too think modeling the health system and trying to understand it is a very useful thing to do. There's also lots of systems tools. Instead of saying, I'll just issue more policy, I'll just issue a new guideline, job done, because job isn't done, it may not be taken up on the front lines, then use system tools, and there's lots of them. And the example I gave was social network analysis, or a depiction, a rich picture, a model of climate change for healthcare, as I showed you in earlier slides. The other thing is you can do a study. That's our contribution, but many people in healthcare also in the system, in local health districts, primary healthcare networks, ministries of health, agencies, are much more likely these days compared to when I was younger to do a rigorous study of what they're trying to improve, rather than just going ahead and trying to improve something in the absence of evidence. Or, like we have shown, you can do a systematic review. How are health systems coping? What are they doing about disaster planning? How can they become greener? So we're publishing several systematic reviews shortly, but that's not the only review of the literature, bringing people up to date with what the evidence says, that we can, you can do a systematic review in an area of your particular interest as well. So that's the background. Now I want to address the actual question on this long excursion to show how we're doing studies which will be meaningful to try and improve the health system by 2030. Let me talk about work we've actually done about 2030 specifically and provide a roadmap, what we're describing as a roadmap to the future. I'm series editor on a series of books on international health reform. The first book looked at quality and safety in 30 countries. The second book, Success Stories, looked at 60 countries. And then we did this is a big doorstopper book, looks great on your bookshelf. I hope you've read it. And if not, I'm going to summarize it in a few slides. And what we looked at in this work is we got 152 countries and said, what do you think is going to happen in your health system if you extrapolate to the future, if you look beyond where you are now across this decade? So this is the book. You can get it on Amazon if you wish, but I'm going to summarize it now. There was 148 authors that we drew on, colleagues from around the world, covering 152 countries. So this is the Wisdom of Crowds book. It's what do people think when we push them to think, how might your health system be better by 2030? And we've published a summary of it in the International Journal for Quality in Healthcare, the ISQA journal. So what lessons can we take from this synthesis I'm just about to give you, from this global outlook on the future to 2030 and how we might get there? So all the coloured in countries are those countries and regions which were included in the study. There was a few countries in South America and the occasional other country that we didn't get to in time for publication. And I'm sorry if you're from one of those countries or you know people from those countries and you missed out. But there's enough countries, I'm sure you'll agree, for there to be enough health systems represented here, most health systems in the world, for this to be a powerful, and 148 authors, a powerful set of predictions for the future, what it might look like. So these are the 5 main trends. There's 5 trends and 9 activities that people are doing to try and create the health system of the future, according to the received wisdom in this book. 5 trends, and these trends are running through health systems. These are going to happen anyway. Trying to create sustainable health systems that are built to last, despite the headwinds that I started with, that all health systems are facing and the Australian health system is no exception. The genomics revolution. How do we harness new data to get precision medicine, to get an understanding of that specific patient and what their needs are, rather than giving them a generic drug or generic treatment? Emerging technologies, new tests, new drugs, new vaccines, new machines that diagnose faster, that scan better. Technology is really rampant. And now we can include AI and information technologies and machine learning. Global demographic dynamics, which are changing. Most populations in the world, in all the countries in the world, are aging. And that brings with it more challenges for healthcare with chronic and complex diseases. And then new models of care. If the pandemic taught us anything, we can actually change very fast when we need to and create, for example, telehealth and telemedicine and remote consultations very, very fast. And that's only one example of new models of care, distributed care, that are emerging. We're going to publish a paper shortly in the Medical Journal of Australia on direct-to-consumer general practice as a new model of care. These are happening now in any case. Nothing we could do will change that. And these will unfold, these 5 trends will unfold across to 2030, according to the wisdom in this book. But there are also 9 initiatives. If you like, these are the solutions. These are things people are doing to try and renew and refresh and create a better health system. And these are integration of healthcare services. Australia is a fragmented health system, state and federal, primary and acute, aged care, community settings, private and public. There's lots of different ways that healthcare is built in silos in Australia, but every health system is looking, how do I integrate so patients don't fall through the cracks? So I provide more coherent, cohesive care. Financing, economics, and insurance. All of this has to be paid for, including all these new initiatives like genomics, AI, new models of care. Patient-based care and empowering the patient. Every health system across the world is trying to say, how do we have collaborative, co-created care? How do we empower the patient and not just have the patient as a passive recipient? Universal health coverage. We like to pride ourselves in Australia that we've got a universal health system. But over the last 20 years, we've been privatising quite a lot of healthcare. Now, there's a place for every health system has a proportion of care that's privately delivered. But have we, in the process of doing that, created a system that has less access and less universality than we would like? Technology and information technology, AI, machine learning, all of these are also initiatives people are trying to exploit, trying to leverage to create better healthcare by 2030. Finally, everyone's trying to cope with aging populations. How do we deliver care? We had a Royal Commission to say we need to be more caring and compassionate and resourceful and provide more resources for a better aging system. Preventive care, we still tend to think about healthcare often through an acute lens. I'm sure that's a big part of the health system. It's very important. But, can we prevent and health promote and include health literacy? Accreditation standards and policy, those are still very important to set standards, to have good policy, to have responsive policy, to have accreditation. So we look at how people are performing and give them feedback, whether it's individuals or organizations or services. And then finally, none of this can be done without a fit-for-purpose workforce. So human development, education and training is at the core of renewing and refreshing the health system to 2030. So this is our roadmap built on the wisdom of crowds of this very large book, where 148 people covering 152 countries all looked at their health system, looked at a project that was happening in their health system and said, how are we going to get to 2030? So a lot of the hard thinking has been done for us by the people who contributed to this book. So the question, how do we get to this version of 2030? factoring in complexity and climate change, which I dealt with earlier and described some of our work. But that's the snapshot. I've summarized all of this in a slide. This is what we need to do to get to 2030. This is the road to 2030 if we pick up all that evidence. Now, you might add a couple or emphasize some of these over others in your work, but we think this is a pretty good description. We're trying to get from a fragmented and siloed system to a more cohesive and joined up system, integrated care. Trying to get from a system that used to just treasure volume, do more patients, get more patients through the system, to creating value. Is this high value care for patients? Value for money. We're trying to move from a system that in the dim dark past was really very provider oriented and set up for providers to a much more person-centered system, patient-based care. Trying to look at a system that used to have many, many barriers to access and affordability, and perhaps still does for many people. Trying to get to wide access without financial hardship, universality. We've come from a system that has many static, legacy-based systems, not data-driven. People guard their data and won't let other people have it. There's all sorts of issues, yet healthcare produces more data. Enormous amounts of information is produced by health systems, but is it usable, intelligent data? So we're trying to, with IT-enabled systems, do machine learning and have AI-enabled systems that are data-driven so that we make better decisions, clinical and patient decisions. There's a lot of unhealthiness amongst the population, and there's a lot of poor health literacy. We're trying to get healthier, health-literate populations. So well-being and healthy aging and health-aware populations are the ones that we serve. We've come from a distant past where we focused almost exclusively or too much on acute care. And we're trying to get to a primary-oriented, health-promoting, preventative system, as well as doing acute care well. In the past, I've done a lot of research on patient safety. For 20 years, I've been studying longer. I've been studying quality and safety of care. We have entrenched levels of poor quality, unsafe care. There's 30-10, the 60-30-10, especially the 60 and the 10. So we're trying to get less harmful, more effective services, high quality, safe, standard-based care. And if we get it right by 2030, we'll have a workforce that's not uneven in its training, is trying to catch up with its knowledge and development, is trying to attract the very best to healthcare, but it's a fit-for-purpose, highly trained and sustainable workforce. So that's the roadmap. If we get it right, healthcare is going to look more like the right-hand side than the left-hand side, because that's where we're coming from. And that's the ideal health system that this book suggested is where we're going to. But the rider is if we get it right. How do we do that? Well, there's many ideas, and this takes us into change management or implementation science or improvement studies. And the Institute does a lot of those. So here's just a snapshot of ideas, and then I'm going to conclude and we can go to Q&A. There's lots of people working on how do we get health system transformation so we can apply that to this model of the ideal health system by 2030 to say, well, what's the mechanism? What are the actions, the activities to get there? How can we work concertedly on producing that right-hand column in my one-slide summary of what we're trying to do to get to 2030 if we get it right? So there's lots and lots of models. I won't bore you with these. You can go to these. The slides are available. They'll be on the webinar. There's lots and lots of models for how to do change management. That's not the purpose of this talk, but we can talk about that sometime in the future. We like the ADCAR change management model, the McKenzie 7S model. We've published an entire book under the leadership of Francis Rapport and myself, transforming healthcare with qualitative research, looking qualitatively at what the performance and the behavior of the system is. So there's lots and lots of work we've done and others have done on this. So I've come to a close. I think I'm on time, Yvonne and Chrissy. I've said a lot, and there's a lot packed in. There are many sources that you can go to, or you can connect with us for some of the papers that are underpinning what I've said. But why don't I pause, take Q&A, discussions, comments, questions, and observations, and thank you for listening. Yvonne, back to you.
Thank you very much, Jeffrey. Very thought-provoking presentation as always, and there are lots of questions and lots of interest. The first one's from Stephen Richardson. Stephen asks, how does Australia compare to our OECD peers regarding the 60-30-10?
Yeah, that's a great question. There's only really 3 countries that have done a comprehensive look across the board at the 60. How much of care is in line with evidence or consensus-based guidelines? We've done 2 on adults and children, and we're just about to publish on aged care settings. The US has done a couple, and the UK's done 1 or 2. So there's really only a small proportion of big epidemiological level population-based studies. There's lots of studies within specific conditions on how much of the care is evidence-based in line with guidelines or RCTs. So we don't know, but we assume that most health systems perform roughly similarly in the absence of any other information. In terms of the 30 and 10, all health systems manage to produce good care and harm patients. All health systems manage to find ways to overtreat, undertreat, have test results that don't get seen, have people fall under our care, get an infection during some surgery. So nobody's done that size of study where every country's involved, or a whole lot of OECD countries. But we think most health systems perform round about those numbers and hover around about those numbers. Now, there are other ways to compare Australian healthcare on other measures, and the Commonwealth Fund in the US does often studies with 15 countries, and Australia often performs well on the various measures that the Commonwealth Fund mobilise, like how good is our primary care, have we got a well-trained workforce, and other metrics. So generally, if you summarise all the international literature, Australia's quite a good performing health system. It runs at about, it costs about the average of the OECD. It's at the OECD average, so you'd expect reasonable results. It probably punches above its weight on many metrics, but it's by no means perfect, and there is no perfect health system.
So Stephen Richardson has a follow-up question which actually fits in very nicely with your answer. So does Australia have the infrastructure and workforce to capture the necessary health data to inform better clinical decision-making?
Stephen, you know the answer to this before you've asked it, but it's a great challenge. The answer is yes and no. Yes, we have the wherewithal, the techniques, the capacity to exploit machine learning, ICT systems that harvest data. We've got some great examples. For example, the Bureau of Health Information in New South Wales is an exemplar of how to use data, gather data, express it. The Australian Commission on Safety and Quality in Healthcare, the Clinical Excellence Commission in New South Wales, and the state departments of health right across the country are doing enormous work to try and harness data. However, we still have some static, legacy-based, landlocked IT and information that we can't get access to or can't readily get access to turn into intelligence. So it's a work in progress. I think we have the capacity. We probably have the data. How do we harness it? Put it in the hands of the right people so they can make timely decisions? Well, that's called a learning health system. And Stephen, you'll have to come back to us for another talk on that topic. But largely, I think it's in our capacity, but there's still a work in progress here.
So the next question is from George Margulis, who talks about the fragmentation of the healthcare delivery systems. And you mentioned this in your presentation, Jeffrey. And George asks, how much does the fragmentation contribute to the challenges as well as to the green sustainability?
Yeah, a lot, George. George, thank you for asking your question. You always ask me challenging questions, George, which I always appreciate. I mean that sincerely. It's a great question. Australia is perhaps a particularly fragmented system. Now, that's not to say that's someone's fault, because all health systems grow up historically to be where they are at a point in time when you assess them. But we've got state and federal interests. We've got public and private, quite a large private sector compared to OECD countries in Europe, for example. We've got different layers of the health system responsible for different bits. And we don't yet have the IT enabled systems for all the various systems to talk to each other. Now, the person fielding the questions is a bigger expert on this than me, and that's Yvonne, who's doing the Q&A, because part of her work, a big footprint of her work, is in integrated care. I think we've got a lot of work to do, and it's going to have to be technology-mediated, IT-enabled, for us to connect up so that we can track a patient across time in their journey, so we can connect providers up so they really have more close to real-time information to make decisions, and so we don't treat the health system as a series of silos. Again, it's a work in progress. Yvonne, you've done a lot of work in this area in multiple studies that are enviable studies. Do you have a contribution to make to this answer?
Look, I think fragmentation is a real problem in all health systems, but particularly in our Australian health system. We're testing a number of models of care that provide more integrated care, and we're finding that it's more cost effective. It's better for patients. Also, providers prefer to work in a more integrated way. But of course, there are significant barriers, particularly in Australia. We're finding that the state barriers can be really difficult to overcome. Data doesn't flow, patient data doesn't flow across state boundaries. And of course, in regional areas, sometimes patients need to go to another state to access more complex care. So we have a lot of work to do in that area. I might go to Farah Maghrabi, who has asked a kind of related question. Why is the Australian health system such a big outlier in carbon emissions compared to nations like the UK?
So if you just compare those two countries, the UK in 2019 done a lot of lead-up work to 2019, NHS England, and the other NHS health systems in Scotland, Northern Ireland and Wales have followed suit, declared that it would get to net zero by a date, set a target, and has done enormous work to try and green the healthcare estate, reduce reliance on, increase reliance on renewables. It has wind farms. We lost a decade, last decade, where we had a whole lot of climate wars politically, instead of making progress. And so we're trying to play catch up. And that is for every industry in Australia, including healthcare. We also are coming off coal-fired generation of energy, and we're a big fossil fuel consumer. And so there's a multiple amount of reasons why. And now we're trying to make much faster progress. For some people, progress is too slow. So that's why our bubble is represented there in the top right-hand corner, Farah, not far away from the US per capita consumption, per capita carbon dioxide emissions. So it's something that I know all governments in Australia are working on, but we've come off a very difficult period, I think, where we didn't make the gains that we should have.
The next question is from John Stubbs, and it's about the consumer and patient expectations of healthcare. We want it all and we want the best. And who should make the call on what we can provide, considering healthcare's impact on climate change?
Yeah, great question, John. Thank you for the question. Look, it's this is an Australian community problem. It's not our health system, it's their health system. It's the health system of the 26 million people in the population. Now, we've done a lot of work on this that I haven't reported on in this talk, John. and that is we've looked at, we've given voice to Australia by running a big survey a year and a half ago, 2 years ago, on what does the Australian population think of its healthcare system and what does it think should happen. I haven't talked about that today. It's just, limited time and lots more things I could report on, but maybe that's, Yvonne, maybe we should do it. The next webinar is on that. I know we've already reported a bit on that. And think through the lens of the consumer, because we've got lots of studies going on, John, about the consumer view. It's true that the consumer, at the time they need care, wants all the care that they need and believe they deserve. And that's true. But how affordable is that? How sustainable is the health system if everyone gets every high-tech thing that we can do for everybody? Or how should we prioritize? These are very tricky questions. Probably isn't enough time now, and you knew that when you asked the question, John, to deal with that. But I think this is a community decision. I think we need to engage regularly and consistently with consumers to understand what they need of their health system. And we need to have an open discussion about what we can provide and what we're prepared to fund in terms of care.
Thank you, Jeffrey. We are running out of time. Perhaps just one very quick question and it's a good one to sum up what we've been talking about. Patricia Greenway asks, so what would be the most appropriate ways to measure getting it right? How do we measure it?
Great question. So we think we've seen many health indicators and metrics of health systems. Some health systems have hundreds of them. Some have 600 or 700 measures of health system performance. If you think back to less than an hour ago when I started with 60-30-10, that paper that we published on that idea has been very influential, downloaded and used by a lot of people, cited a lot of time. If we could get those 3 metrics improved, we would have a better health system, is my claim. If we had more care that was high quality, in line with guidelines and level 1 evidence, where they fit with the condition, if we had less waste, if we had less harm, we would have more resources and a better health system. So maybe we should start there and try and beat those numbers. Maybe that way Australia could become the best performing health system.
Thank you, Jeffrey. I think that's a fantastic place to end. Thank you again, Jeffrey, for the presentation. Thank you, Yvonne, for hosting. Thank you to our audience. Now, everyone who's
Chrissy, just one thing. Could I just acknowledge all the people who contribute to all this work? Could I also say, here's some other books that we've been involved in the Institute. Here's some forthcoming books, and this is how to get hold of me.
Perfect. Now, everyone, you will receive a recording to this presentation, which you're welcome to share. And you can also go on our AIHI YouTube channel to catch up on any other presentations that you might have missed in the past. Okay, thanks, everyone.